Welcome to Unit 2 of Physiology of Activity. We are going to continue our discussion of exercise physiology principles using special populations to tell a story. So our next case is going to be a woman with arthritis. So Sasha is a 55-year-old female. She has a 3-year history of progressively worsening knee pain, bilateral knee pain. Her knees are stiff for about 20 minutes in the morning. She has difficulty walking more than 30 minutes because of pain. Pain worsens with squatting and descending stairs, and sitting reduces her symptoms. Patient is 5'6", weighs 200 pounds. Her diagnosis is bilateral knee osteoarthritis, and she has been told by her physician to lose weight and get physical therapy. So, as a reminder from PathoPhys, I'm going to pull up the PathoPhys slide we used in the spring. Osteoarthritis is a condition where the articular surface of the bone that's normally covered in hyaline cartilage gets disrupted. The disruption of collagen matrix can come from a number of different sources, and as a result of this disruption of the matrix, there's an imbalance between the ability of chondrocytes to repair themselves and the failure to do so, which results in death of those cells. And eventually you get stripping away of the hyaline cartilage, where whole sections kind of get sloughed off. As the disease progresses, things start to look really bad in the joint because subchondral bone becomes exposed, meaning it's no longer covered with that squishy absorption hyaline cartilage, but rather subchondral bone becomes the articulating surface. This can lead to subchondral cracks where synovial fluid leaks in and you can get cysts. You get growth of new bone called osteophytes that narrows the joint and creates even more abnormal loading within the joint. So, for many different reasons, arthritis is a disease of repeated abnormal stress on the cartilage. And it's a vicious cycle, right? Once you get a disjointed joint surface, that causes abnormal joint loading, which causes additional stress on cartilage, and kind of around and around we go. The piece of this that is important to include in the conversation about arthritis is the impact that weight might have on this. The more weight bearing down on a joint that already has abnormal joint loading can increase symptoms and speed up the degenerative process. So it is a good idea to discuss with patients weight management, weight strategies when they're dealing with the pain and symptoms of osteoarthritis. So it is appropriate that these are put together, this getting therapy for your knees and losing weight. Certainly there's a number of reasons that someone might be including losing weight as part of the conversation, just the obesity and the increased risk of diabetes and other cardiovascular disease. Increasing your weight can increase the risk of certain cancers. There are a lot of times when we will be part of these conversations. So before we really get into the arthritis piece, I just want to have a discussion and kind of spend some time in this losing weight piece and what kind of role we play in that. So when we talk about somebody's weight, it's really important because, as I just mentioned, obesity is associated with increased risk of cardiovascular disease, renal disease, diabetes, osteoarthritis, some cancers. And historically, patients were being put into different risk categories for those things that are associated with obesity based solely on what's called height-weight tables. Basically, if you were outside of the range, you were considered overweight or underweight, depending on which side you fell on. But there is an important distinction between being overweight, heavier, and being over fat. And I'm hoping to impress upon you the importance of the composition of our bodies more than just the weight, especially as it relates to a lot of the risk factors that come with obesity. That being said, these are the height weight tables, and these are called the MetLife height weight tables because they were originally designed by an insurance company to help identify those individuals who are at risk for making decisions about health insurance. Now, there are a lot of problems with these tables, one being that they do not account, as I mentioned, for body composition. We do not know if this person's weight is based on fat or lean tissue, like being a very muscular person. The other huge issue with these tables is this data was collected almost exclusively from a white population, and it's just not applicable across the general population. So these are largely kind of been put to the wayside, and they're not used as much because a lot of the problems with how the data was collected. But you'll still see them referenced, and I wanted you to know the history of the height weight table. Clinically, we have really moved more to a body mass index, or BMI. And BMI is handy, and it's very popular with clinicians because it's super easy to determine. You just take somebody's weight and you divide it by their height squared, and you get a BMI. The problem is that, as you can see from the equation, BMI basically has the exact same problems as the height weight tables. It's just a subset of the height weight tables, really. It doesn't account for how much of you is lean or fat, and that's what this cartoon here is showing. These two individuals have the exact same BMI, but these are obviously two very different health risk category individuals. So I'm going to kind of lay that out there first and then tell you I don't think these are going anywhere. BMI is extremely popular, partially because it's extremely well validated. There is so much normative data on BMI, and it correlates really well with mortality. So this graph is showing body mass index on the X, right? People are getting larger as you head to the right. And you can see that as the BMI increases, so does their mortality risk. So as your BMI gets higher, it is very well correlated with an increased mortality. So for that reason, it's easy to collect, and it has tons of normative data, and it correlates with mortality. It's not going anywhere. While I'm on this slide, I do want you to pay attention to the fact that as BMI gets larger, your risk goes up. But if you start going the other way and start looking at lower and lower BMI, it actually starts to uptick again at the very low end of BMI. And that's an important thing while we're on this page to keep in mind. A lot of what today's discussion will be about is about losing weight and weight management and obesity. But of course, there's a group of individuals who have an unhealthy association with their weight and thinness and eating disorders that fall into a higher risk category because their BMI is so low. A certain amount of body fat is necessary for our health, for the protection of our organs, and for other things that we will discuss. Just while we're on this slide, I didn't want to lose sight of the fact that, just losing weight is not always the best thing. It's where do you fall on the spectrum of a weight. So for your studying purposes, I would definitely know how to calculate the BMI. And I would also have a good kind of general feeling about the cutoffs for BMI. I would certainly never give you a test question where it was 18.4, but generally speaking, you should kind of know that the low 20s are normal, and when you get above 30, you're obese. I'd like you to have just kind of a working knowledge because BMI is used in so many medical records, and it's a really quick snapshot of what you're going to walk into. It can help inform, if you need to bring an assistant with you or what kind of walker, gait belt, all that stuff. It is a good thing to be able to have that snapshot in your mind. When it comes to prescribing weight loss and weight management discussions, BMI is a poor tool. It doesn't work well because it does not take into account body composition. So it has a role in our world in that it helps quick snapshot, give you an idea of a general risk category, but it really wouldn't be the tool used when you're having a rich conversation about weight loss and weight management. So Sasha's 5'6" and weighs 200 pounds. So let's just walk through and calculate her BMI. So if you remember, BMI is simply your weight over your height squared, as long as you are in the metric system. So I would like you guys to feel comfortable being able to move back and forth between the two. So if she is 5'6", that means 5 times 12 plus 6 inches. She is 66 inches tall. Oh, that's supposed to be inches. There we go. And we just want to convert that to meters. So 1 inch, if you're not familiar, is equivalent to 0.0254 meters. So when you have somebody in inches, you simply take their inches times a conversion factor of 0.0254 to get them to meters. So 66 inches times 0.0254 meters means she is 1.68 meters tall. And her weight, she's 200 pounds, and we want to be able to convert that to kilograms. So one kilogram is 2.2 pounds. So when you have somebody in pounds, you just need to divide by 2.2. And that's how you get it over to kilograms. So she is 91 kilograms. I would definitely feel comfortable making those conversions on your own, kind of memorize those conversion factors if you don't already have them in your head. So Sasha's BMI, she is 91 kilograms over 1.68 meters squared, which means her BMI is 32 kilograms per meter squared. So 30 is our cutoff for obesity. So it is an appropriate conversation to be having with her based solely on BMI without looking at her body composition yet, which we will. That weight might be a factor in her arthritis since she is obese based on her BMI measurement. And this was likely the snapshot that her physician used to come up with the recommendation that she should lose weight. But now that she's come to you, I'm hoping that as physical therapists, you are going to take the time to do some assessments of this patient's body composition before you'd make any recommendation on weight loss goals. So body composition is the amount of your total body weight that is lean, which is muscle, tendon, mineral water, and the amount that is fat. Body composition is a very good way to assess overall health and fitness because it takes into account your weight and how much of that weight is fat. It is the go-to way of setting reasonable weight loss goals. And it's much more appropriate to do body composition in athletes because they might have a higher amount of lean and really not fit into the normal validated normative data of BMI. So there's a lot of different ways of taking these measurements. Let's first just talk about fat distribution. Instead of like percentages of lean and fat, just kind of where is the fat in the body? And it matters because I'm sure you guys remember this whole apple versus pear shape, where the apple shape has more visceral fat and has a much higher risk profile for cardiovascular and endocrine disorders. Whereas the pear shape means you carry more weight in your lower extremities, you have less visceral fat, and it's a lower risk profile. So if nothing else, you want to at least assess fat distribution because the distribution of fat is a much better indicator of the risk of the problems associated with obesity than just looking at height, weight alone. And they're super easy. They take almost no time, and it's a tool you all have in your, every single clinic in the PT world will have a tape measure. So you can do waist circumference and waist to hip ratio measurements. Both of these are beneficial because they take into account the degree of visceral fat. And you can see the waist circumference, the normative data is given in centimeters, and the waist to hip ratio is that comparison between how much is visceral and how much is in the lower extremity. And obviously, the more that is in the visceral area, the higher the risk category. So these are very easy. You do not need to memorize the charts that are in your notes for this, the normative data. BMI, I do want you to know the numbers because it's kind of the language of clinicians across fields. This, if you are prescribing weight loss goals, you can look up their risk profile for these measurements. When we talk about body composition, the gold standard are going to actually be looking at how much of your body is fat or your percent of body fat. Now, historically, there can be direct assessment of that where after a person dies, they can do direct dissection or chemically dissolve the body into the different components to do an analysis of the fat versus fat-free components. Obviously, none of those are possible when the person is still alive. So what we have are indirect assessments of the amount of our body that is fat. And hydrostatic weighing for many, many years was the gold standard. Someone's entire body is submerged in the water, which gives you a measurement of the body's volume. And then you can do an assessment of how much water is displaced to give mass, and then you can use that to estimate body fat. We now use dual energy X-ray absorptiometry, or DEXA, as the gold standard. It's been validated against hydrostatic weighing and is now considered the gold standard for these measurements. It uses dual X-ray beams to penetrate bone and soft tissue, and basically kind of figures out from those measurements how much of your body is mineral, total fat, and fat-free mass. So DEXA is used a lot for bone mineral density because it is much more accurate than standard X-ray, but it's also the best way of measuring body fat assessment. In the top here, this is the, I don't have writing, here we go, bioelectrical impedance analysis. Basically, it's this little handheld device, super easy to use. You punch in the patient's kind of age, height, weight, and then they hold on to the two handles, and small alternating current will flow between the two electrodes. And the machine times how long it takes to go from one hand through the body and back to the other. So the underlying principle is that electrical flow will move faster through lean tissue and water, and fat will impede the flow of that electrical current. So based on the time it takes to make that circuit, they get an estimate of the total percent body fat. And then the last one is a skin fold assessment, where, as you can see in this top panel here, you take a measurement of the thickness of the skin. So when you're doing a skin fold assessment, you pinch the skin away and you see how thick it is. So you're basically, in your fingers, you have some skin and some subcutaneous fat. And largely speaking, skin thickness is the same across people. Outside of the metaphor of having a thick skin, our thickness of our skin doesn't really vary. So the difference that you'll measure between patients is how much subcutaneous fat is there. As you can see in your notes, this is a pretty valid measurement. It's about 3 to 5% off from hydrostatic weighing, so that's not bad, and you just have to be very careful about doing this accurately. So these are measurements you're going to do in lab. And if you've already done them previously, you can just show competency in lab. If you've never done them, we'll make sure you can do them right. But it's a really easy way to get a wide variety of, I should say, a large collection of information on your patient to make really good weight loss recommendations. Of note, skin fold assessment does these point measurements, but it doesn't really account for fat patterns. So where the waist circumference measurement and the waist to hip ratio is looking at fat patterning, this is looking at percent body fat rather than where it is in the body. So for our case, our woman that's come to see us who's interested in losing weight, we do a waist to hip ratio measurement, and she's 0.92. And her body fat percentage is 38%. So if you look at the percent of body fat as it relates to the patient's kind of fitness level and obesity level, it is again good to have in mind kind of what these numbers mean for both women and men. Now, women have a higher amount of essential fat than men. And by essential fat, we are talking about the fat that surrounds our visceral organs and is necessary for health. So this is very different than our storage fat, which is when we put away excessive amounts of triglyceride for use later for energy. And any weight loss recommendation should not even come close to essential fat. That's where you start to get that uptick in the BMI, where there's an increased risk when weight loss gets too low, because fat does serve an important organ and it's very protective. It serves an important purpose and is very important for the health of our organs. It's the storage fat that we are talking about when we normally discuss someone being over fat and having increased risk of heart disease and type 2 diabetes and the rest. So it's important in some cases to really talk patients through that not all fat is bad and a certain percentage of fat is required for health. So our patient is a woman, and she was 38% body fat. So now we came in and we knew her BMI put her into the obese category, but we took it one step further and we assessed fat patterning with a waist to hip ratio, and we got her percent body fat. And having the percent body fat can help to set really specific good weight loss goals. So I'm going to walk you through how you determine what would be an ideal weight. And the goal here is to make any weight loss goal based on how much lean mass would you like to have? Or the flip of that, what is your goal of your body fat percentage? So you have this written out, the steps are written out in your notes. Let's do them here together. Step 1 is to determine body fat percentage. So you could do that with DEXA, the bioelectrical impedance, or in this case, we did skin fold measurements, and we found her percent fat to be 38%. And when we went to our chart and looked at what that percentage meant to her, she was obese. So we have to decide what is our weight loss goal. And remember what her purpose of her goal is, because that can impact. Her goal is to reduce weight, to take some of the load off her knees that are causing her a lot of pain because of arthritis. So she looks at the chart and she would like to be at the low end of average. And the two of you talk through the implications of weight loss and what that might mean, and you agree on a goal of a body weight percentage of 25%. So her goal for her weight loss plan is to have a percent fat equal to 25%. So how do we get her there? Step 2 says calculate her current fat weight. So we know her weight, she was 200 pounds and we converted that to kilograms. So her weight is 91 kilograms right now. And we know that 38% of her is fat. So you can take her weight and multiply it by the percent fat, which is 38%. And you will find out how much of her 91 kilograms of weight is fat. So 38% of 91 is 35 kilograms. And that's 35 kilograms of fat on her current frame. Step 3 is let's figure out how much of her body is lean. Because when we set weight loss goals, our goal is going to be maintain her lean body mass and lose fat. And this, we will talk through weight loss things later in the semester, but there are weight loss plans that you can lower your total body weight, but you're breaking down protein and you're losing lean body mass. And this isn't the healthiest way to lose weight. You want to keep your protein, you want to keep your lean, and you want to lose that excessive storage fat that puts you in the higher risk category. So if you want to calculate her lean body mass, we already know how much of her is fat, right? So you could take her original weight. I wonder if I should write this out for you guys. So you take her body weight and you subtract off the amount of that is fat. So you can subtract off the weight of fat. And that will give you her lean body mass. So we have 91 kilograms is how much she weighs, and 35 kilograms of that is fat. So her lean body mass is 56 kilograms. So step 4 is how you calculate her target weight. So it's written in your notes like this. Target body weight, and I'll just put body weight here. Target body weight is your lean body mass divided by 1 minus your percent fat desired. That's the goal. Desired, can't spell it. Divided by 100. Now, the reason this little bottom section might look funny to you if you haven't done these before is 1 minus percent fat desired. What is our percent fat desired? It's 25%. If you divide that by 100, our percent fat desired is 0.25, right? That's our ultimate goal. So 1 minus 0.25 is going to give you the percent that is lean. So you'll get 0.75. So basically your goal is that 75% of your body weight is lean. That's where this 1 minus percent fat desired comes in, if that threw you off at all. Because what you're really looking at here is at the end of this, your target body weight. If you multiplied that by 75%, you would get your lean body mass. So if you plug and chug the original equation and you put in lean body mass is 56 kilograms and you divide it by 1 minus your goal, which is 0.25, your target weight is 75 kilograms. And if you wanted to convert that back to pounds, right, you just simply multiply by 2.2, and that's 165 pounds. So if you're then communicating that to your patient, you're saying, how much would you like to lose? Her current weight is 200 pounds, and her goal weight is 165 pounds. So the goal here is that she loses 35 pounds with whatever is your prescribed weight loss plan. So the ultimate goal, if she's successful with this, is when she's finished, she will weigh, let's change our color here. She will weigh 165 pounds. Of that 165 pounds, 25% of it will be fat, and 75% of it will be lean. Let's just look back at those height weight tables. She's a woman, so we're over here. She's 5'6", so this is our section here. Let's say she was a medium frame, the tables recommend her to be between 130 and 144 pounds. By taking the body weight percentage, the body fat percentage, excuse me, and we went on the low end of average, right? We went to 25% for her body weight percentage. Her goal weight is 165 pounds. That would be considered overweight on the MetLife height weight tables. And yet it's totally appropriate for this patient. It's a healthy distribution of fat. That's just to highlight the weakness of those tables and to encourage patients to think about their bodies in terms of lean versus fat instead of just a number on a scale. Because there's many ways to be healthy, and the amount you weigh doesn't really matter all that much. It's about what your body has and the healthy distribution of the good stuff and the bad stuff, really. So with not a lot of time, we've got some really important measurements on Sasha. We know her BMI category of obesity. We know her fat pattern using waist to hip ratio. We have a percent body fat measurement that gives us a really specific, attainable weight loss goal that will both improve her cardiovascular health risk profile as well as take some of the weight off of her osteoarthritis. So we will talk more about how we prescribe exercise for weight loss, but let's move into the arthritis piece. So I'm going to end this portion of the video here for a good stopping point, and we'll pick up talking about arthritis at the beginning of the next video.